the concept and progress that we anticipate for newborn screening in general. So some things about this. I do not have to say this to this crowd, and newborn screening saves lives. It is a fundamental improvement in the way we care for children. It revolutionized public health and medical care for all of these conditions that we screen for. There's no debating that in any way. It changed the way we approach these disorders and made them conditions that you can live with instead of conditions that kill babies. So I'm a big fan of newborn screening. It changed everything I do professionally. So, some reminders. Most of you know these things, but I'm just going to say them. I'm going to put on my glasses because I can't see everything. Okay, so newborn screening is a highly successful public health program. The disorders that we screen for aren't evident at birth, or you wouldn't need a newborn screen. You'd just know somebody has the diagnosis. And so most of these conditions that we screen for are identified using analytical lab techniques in a laboratory, in a centralized public health laboratory. The key point here is that this is a public health mandate. That means every baby, with some exceptions, but pretty much every baby should be screened. And that's done not with the specific consent of parents. It's a mandate, and that means it carries a very high consequence. This lovely picture, just so everybody can ooh and ah, is my own grandson, Adam, having his newborn screen in Washington, D.C. The nurse thought my in-law, my children were crazy to have this picture. And then when she found out what it was for, she went all in and she demonstrated, and he got a very normal newborn screen. Thank you, Adam, for being our spokesbaby today. All right. So the key to the idea that this is a public health mandate is when you add to the mandated screen, you really have to know what you're doing, and you have to plan for it, and it has to be consequent. Because it impacts not just the original, screening is a risk assessment. It's not a diagnosis, it's a risk assessment. And it changes all the subsequent care of that baby. Whether it comes, what you're doing is positive or negative. And you heard Dr. Ronaldo talk about that yesterday. There are incredible benefits, but there are risks to newborn screening as well. You don't want to make either the positive or negative mistake. And the trick that we have had in some ways about newborn screening is that when we think about how much newborn screening costs, it can't just be the test itself that we factor into those costs. It has to be everything that follows from it. We don't do that, by the way. We think about how much the test costs, and we emotionally think about the positive and negative results, but we don't think about the longer term costs to you, the families that are impacted by this. All right, so newborn screening is actually a system, not an event. It goes everything from the pre-testing, that means education, which we don't do that well, to getting ready to sample properly. If you don't sample properly, the test won't be valid if the timing's wrong. You have to get the sample to the lab in a timely fashion or it won't be effective. You have to do the test very well. You have to interpret the test properly. You have to give the results in a meaningful fashion. How many people remember like it was yesterday the moment they received their newborn screening result? Like yesterday, it's like you can still burn it in your memory, that lady with the burning pain in her belly? That's in your hearts with that newborn screening result. They have to, we need to have great diagnostic testing to clarify that risk assessment we've provided to you with a newborn screen. And then, here's something else we don't do particularly well. You heard us talk about this yesterday. We don't do a particularly good job of talking about outcomes, and we haven't done that great a job of really being clear in our case definitions. What is a case of this or that? And if you're going to subdivide it, how do you do so in a meaningful way so you compare apples to apples in outcome? So, it's a system, not an event. So, why do we screen? What is the process by which this is done? And most of this originally, the way we think about screening was based on a World Health Organization paper by Wilson and Younger. And this was not about newborn screening, by the way. It's about public health screening in general. And they have a whole series of criteria that they say justify public health screening. Things like, it should be an important public health problem. I think all of us are good with that. Should be a treatment for the disorder. They should have a way to diagnose and treat. There should be recognizable early stage so that you do the test and apply when it's meaningful. It should be acceptable to the population, the test. That means you wouldn't like say, well, the only way we can diagnose this is to take off baby's left toe. That's not an acceptable test. And for some people, drawing blood is, doing the heel prick it's a big step when you have a new baby. So it has to be acceptable. The natural history of the disorder has to be defined. Well, we've done only quasi on that, but I'll take that we know that to a large extent. You should have a policy on who to treat. You should continue to provide yourself some self-feedback about this. It should be a continuing process. And so those are really, I think, pretty good criteria by which screening would be established. Now, newborn screening is, I think, a more specialized case. It's not everything, but it's an essential public health responsibility. And so the policy is really about the newborn themselves, and as again, the system is not a test. Medical homes need to be involved in this. And I think that's another place where we're plus minus on in terms of implementation. And the choices for screening have to be based on evidence and expert opinion. You heard a little bit about finding evidence bases yesterday when you heard about diet. That's a complex process, that evidence review, to really know that you're doing things for the very best of reasons, the best science available. You have to have a criteria for specific targets. And, okay. And you have to have a plan for storage and use of information. So the key to this, once again, is that newborn screening is a system, not a test. So in the context of newborn screening, like the ones that many of your children underwent and that some of you personally underwent, a primary screening target should be identifiable at an early phase of life when it wouldn't be clinically detected. We should have a test with appropriate sensitivity and specificity. You heard Dr. Ronaldo yesterday talk about the positive predictive value of newborn screening when it's magnificently applied. But you need to have demonstrated benefits of detection, of intervention, and treatment. I will argue, and I think most agreed, when they first decided to have a recommended uniform screening panel, that all of the disorders that affect persons in this room fit on that key. Dr. Ronaldo and others conducted an expert panel to decide what was going to be on the first pass of the recommended uniform screening panel. They contacted experts all over the country, and people scored them, and the number one, you can't see it here, but the number one disorder that fit on this recommendation that everybody universally agreed had the highest score was MCAD deficiency. And all of the fatty acid oxidation disorders on the primary panel were very highly scored as well. There are a group of conditions that were identified by this screening process that are referred to as secondary targets. These are conditions that we either don't have enough information about, we don't know if they're a disorder that can or should be treated, we might not have a treatment for it, but the information in tandem mass spectrometry carries them along, and people are loath to not share information about information they have. So the secondary targets are less well established, but I think in general, bit by bit, states have also adopted the secondary targets. The problem we run into sometimes is that those secondary targets, people treat them like they're primary targets, and that we have as much knowledge about them as we do our primary ones. So that's a bit of a problem. Now, there are a whole host of things that probably deserve some newborn screening, but for which there's no good test. How many of you all have heard of the group of conditions called urea cycle disorders? Okay, so lots of you have heard about this. Those disorders kind of fit into two groups. Those that can be newborn screened because they have metabolites where the blood level's high, so it's easy to check them. And those which are just as serious or more serious, but for which there's no specific metabolite that does a good test. And so those babies are still subject to what your babies used to be, which is sudden presentation of catastrophic nature in the neonatal period. Very devastating events. So those are the kinds of things, in my view, they're good targets for future newborn screening if we can have a good test. All right, some things that we learned when we did this whole screening process, of which I was extremely thrilled, and all of us professionally were very proud of that event. And those who supported it should be justifiably just really all over themselves for really being good about it. But there's still some things that came with this. Well, so for example, if we get ready to add new things and what we already have, when we chose these things, we knew about the disorders that presented before newborn screening. We knew about the most severe forms of them, but we didn't know that there'd be similar disorders easily picked up that had different timings of presentation. We've heard about that today from some of the older individuals affected with these conditions. There's quite a variation of severity. Oh my goodness. So this is a lovely, you probably don't know what a picture represents, but that's my picture of an iceberg that I stole from the internet. Because what we found out when we started screening for things at Holy Buckets, the disorders that we thought we understood, we don't, because there's such a variation in presentation, and there are many people who get mild forms of those conditions. And those conditions, we don't know how aggressively to treat them when they're mild. So everybody gets the same treatment, whether you have mild or severe conditions. We didn't take into account when these recommended uniform screening panel disorders were defined, the cost of diagnosis, the cost for treatment, and as Mark so cogently described to you guys, the availability and accessibility for expertise for treatment. That wasn't really accounted for, and it's been a big challenge to us since we started doing these screening processes. So some of you are familiar, but others may not be, of the process by which the federal recommendations for addition of disorders to newborn screening panels takes place. There's a Secretary's Advisory Committee, a Secretary of Health and Human Services Advisory Committee. It's a committee constituted in statute by Congress for a study of the heritable disorders in newborns and children. Notice it doesn't really say anything there about newborn screening. It doesn't say anything about metabolic diseases. It's a pretty general term. In practice, this has been the committee that both defined and continues to extend the recommended uniform screening panel for newborns. All right, so as Kathy said, I'm a member of this. I'm not speaking on behalf of that committee, and I am not in my role as a special government employee that I would be when I was at that meeting. This is my personal opinions that I'm sharing with you today. All right, here's a complication for that recommended uniform screening panel. You heard Dr. Rinaldo say it wasn't fair that one state was different and another was not, and so we created a recommended uniform screening panel, and that got us exactly here, which is that in the United States, every state decides what it's going to screen for. No matter what the recommendations are, states have to decide. And they have their own internal processes for doing that. Now, the downstream effect of that is that individual legislatures, on behalf of interested parties, primarily parents, can mandate screening of favored conditions without going through that evidence-based review process that the federal panel requires for addition. The consequences of this are that we don't have a recommended uniform screening panel that's uniform, or we have that panel, but it's not implemented uniformly across the states. And that it means that when you add disorders by legislative mandate in a state, it may or may not be accompanied in that state by any resources that will help either support the testing or the care. Because who could feel better than saying the legislator added this test and they have a beautiful baby that they will save by doing that, but they don't think through the whole process. They get a feel good, but they don't own up to their responsibility for really dealing with the system, not the test. Doesn't that make sense? It's a system. So what are our limits in newborn screening? What should we be thinking about? Well, there's some real practical ones, and then in my view, there are some philosophic ones that we as citizens, you as parents, you as advocates should be thinking about. One of the things is that no matter how hard we try, and some of you may have experienced this with your children, time waits for no one, And if you sample at 24 hours, which is pretty much as early as our current technology allows us to do, and you dry the sample, it has to be dried properly, and that takes a certain amount of time. It sounds weird, but it takes time. If you send it off when it's wet, it's no good to you. And then you have to transport it. And even if you're right close to the Department of Health, that process probably takes 8 hours. Then you have to log it in a system, and it's like high throughput system. It's got to follow a pattern, a plan, and then you have to run the test. And if you're in the best of laboratories, that's going to take 24 hours. So now you're out to 2 days plus a little bit. The baby's now 3 days old, right? So if you get the sample at 24 hours, it's a miracle to get a result on day 3 of life. And a disorder that presents at 48 hours of life can't be helped with newborn screening as it stands. Nothing we can do with our current technology changes that at all. And that is a problem for some of the disorders in this room. I'm going to call out specifically MCAD deficiency. If a baby has poor intake and people haven't put their piece of head together and they're being very religious about you can only breastfeed and it's a first-time mom, and then the baby's fasted a little more for circumcision, and all of a sudden now this baby hasn't eaten since it was born, that baby's going to get into trouble, and it's before they'll get results back, right? So time waits for nobody. Here's a good example of that. We had a full-term infant. He was appropriate for gestational age. He was born with fabulous APGARs. He had a little bit of a low glucose in the nursery. They fed him a little bit. He did fine, and they sent him home. He had a normal hearing screening, and he had his newborn screening sent out. But at 48 hours of age, he's just 2 days old now. He comes to the emergency room, and basically he's gone. He didn't survive that few hours. No newborn screening in the world is going to test for that, and it turns out for this baby, newborn screening would have helped him anyway because he had a disorder that's not detected by it. He had OTC deficiency, a urea cycle disorder. He died of high blood ammonia, had a coma and died. So, time course, stories that are very poignant. So, if we can't stop the clock, if we can't stop it, should we change the clock? Should we be doing it differently? Is there any way we can change the timing of screening? Should we be trying to pretend we're screening for early onset disorders? Are we being honest with ourselves and saying we're screening completely for the ones we already have? And would early ascertainment make a difference in outcome, and does pushing that time back justify that? Because it would mean a major change in systems. These are questions, I'm going to present questions I don't necessarily have answers for. So, question is, that I'm going to throw out here, and again, one of the things you guys should be understanding, that you as advocates and people who know more about rare disease than almost anyone, is that if there is another tool that we should be arguing for that will help another family, that we should think about them. And are there other times we could screen? Could we do carrier screening? Could we do cell-free DNA screening before the baby's born to detect certain disorders? Those technologies begin to emerge. We need to, I think, always be expansive in the way we could treat early diagnosis to save lives. So we'll see if that evolves. So one of the things that's happened in newborn screening is, after we got the recommended uniform screening panel, I would argue we hit most of what we would call low-hanging fruit. We got the disorders that really deserved newborn screening. And for all the quibbles I've given you about, is our timing right and all those things, I would never go back to not screening for those conditions. It changed fundamentally how we approach those. But we've now added some other disorders that don't quite fit the paradigm we started with. And an example of that would be lysosomal storage diseases. These are diseases that slowly accumulate damage to a child. If you don't treat them, ultimately the kid will develop a very different physical appearance. And in many cases, the disorder, because of the cumulative damage and storage, will cause intellectual disability and ultimately death due to the complications of the storage. So they're very difficult and very profound diseases. But they're not, and they are also not evident at birth. They may or may not have neonatal and early onset, early infancy presentations. And the treatments are effective to varying degrees. They're not quite as cogently defined as